tutorial for practice of cardiac sonography 3, reporting adult congenital heart disease and reporting uncommon findings. I'll spend most of my time discussing reporting congenital heart disease, but what I want to say from the outset is that this is not entirely limited to congenital heart disease. What I want to help you to appreciate is some of the ways that you want to approach reporting echocardiographic images and measurements in general. So the contents, firstly, writing reports for patients with congenital heart disease, reporting uncommon findings, and some other important matters as well. And afterwards, the aim is for you to be able to compose a written report of someone with a simple congenital heart lesion, provide a clear description of uncommon echocardiographic findings, and execute additional important matters following an examination. Well, if this is the ideal structure of a report, one of the things I just want to remind you of is the fact that it's really important to get patient information right. When I first left uni as an undergraduate, I worked in pathology for a little while, and on one occasion I happened to get patients' name and identification wrong, and it caused a real hassle in terms of having to sort of backtrack and locate different things so that the appropriate diagnosis was given to the right patient. That's an example not directly related to echo, but it's certainly as an indication of the fact that if you get things wrong in terms of a patient's ID, things can be bad, and it takes a little bit of time to fix them up. But having briefly mentioned that, I want to spend most of my time talking about how to summarize and how to report congenital heart disease and provide a good summary of what the images and measurements show. So the way I thought I'd go about doing that is, rather than just going through a whole lot of reports and saying perhaps what's good or bad, is actually presenting some cases and how they should be reported. But first of all, let's start in a similar way to the tutorial for congenital heart disease was started, and that's with some stenotic lesions, and in particular the bicuspid aortic valve. And with stenotic lesions, when reporting, I recommend that you think of these three things that need to be highlighted in your report. Firstly, the anatomy and motion of the valve. Secondly, the gradients through the valve, and also some secondary effects. So with regards to the anatomy, obviously you want to indicate, if you're looking at a bicuspid aortic valve, clear indications about that particular valve. As Kenny mentioned earlier on, oftentimes it's easiest to recognize a bicuspid aortic valve during systole. So can't do it exactly very easily here, but on an echo machine it's quite easy to slow your image down, and that's a nice way of confirming that. And then you can come up with a better report in terms of an indication about whether it's a true bicuspid valve, or more commonly a valve with a raphe, and most typically the raphe is between the right and left coronary cusps, as is the case on the looping image down the bottom there, although As you can see, the right coronary cusp is significantly calcified, and so that's perhaps making it a little bit more difficult to recognize the raphe. So the valve anatomy and its motion as well. In the bottom right slide, can't appreciate it because it won't loop, but there's a certain doming of the leaflets in systole, and if you do appreciate that, you can be pretty certain that when you come to measuring the gradient through the valve that it's going to be increased. So as soon as you start seeing things like this, you know you're going to be wanting to look at them more carefully. And in terms of gradients, well, you want to provide information about the peak and the mean gradients, and so tracing the transaortic gradient measured with continuous wave is the best way to do that, because you get the peak and the mean. Let me remind you, of course, that it's really important to develop skills so that you can utilize the PEDOF probe, which, because of its small footprint, is very much suited to getting in between rib spaces and getting into sort of perhaps positions that you can't quite with the standard probe, and therefore oftentimes enables you to acquire a higher gradient, because you're able just to align yourself a little bit better. And then importantly, you want to report the secondary effects. So any valvular lesion, if it's significant and there's any length of time related to that lesion, is going to have secondary effects. So as Kenny mentioned earlier on, some of those include left ventricular hypertrophy, or more specifically concentric left ventricular hypertrophy, dilatation of the aorta, whether it be at the sinuses or the ascending aorta or both, and coarctation of the aorta. So what might that look like when you can actually come around to writing about that? Well, let's combine the anatomy and motion and peak gradients. So you might want to write something like bicuspid aortic valve with apparent raphe between right and left cusps, increased cusp thickness with doming and systole, max and mean gradients 50 and 30 millimeters of mercury. And then importantly, you want to list the secondary effects: moderate concentric hypertrophy, dilated aorta, and aortic coarctation. You want to make sure that you cover all the bases. Now, that's not to say that you write all this in one paragraph. So the report may be structured in a way that doesn't quite enable that. But if there is the possibility to make a summary, and you're wanting to answer the indication, these are the things that somewhere in your report you want to make very clear if you're reporting a bicuspid aortic valve. Okay. Another stenotic lesion. What about in cases where in the valve itself is okay, but the stenosis occurs somewhere else? Well, in this particular example, we've got stenosis that is occurring above the valve, a supravalvular lesion. So obviously we want to provide a report that indicates that the lesion is not related directly to the valve itself or to the valve's motion, and therefore we want to be very clear about that. But still, we want to provide some indication of how significant that is. So we talk about the gradients and the secondary effects. So in our report, we want to say something like supravalvular pulmonary stenosis, and then expanding on that, thin membrane 5 millimeters superior to the pulmonary valve, peak gradient 50. Just like on the left-hand side, if you've got stenosis on the right side, you're going to have a hypertrophy, but obviously in this case, the right ventricle. And some of the secondary effects, a little bit like aortic stenosis, which can have a secondary effect on the aorta itself. there can be some dilatation of the branch pulmonary arteries in this particular case. So you want to, if you can image them clearly enough, to measure that and report on that as well. Let me just stop sharing. Is any questions yet? Just looking at the chat. Nothing there. Okay. Okay. So regurgitant lesions this time. Similarly, there are three things that generally we want to focus on, and one recurring theme here obviously is any of the lesions related to the valve, whether they be stenotic or regurgitant or a mixture of both. You want to talk about the anatomy of the valve, because that's very much related to the cause, obviously. And then as well, you want to talk about the degree of regurgitation and the direction of the regurgitant jet and any secondary effects. So what might, in that particular case, the report, how might that report read? You want to talk about the valves as, in this particular case, mildly thickened. You want to talk about the regurgitation. You want to say whether it's central or eccentric, and that's important information. Because remember back to things that we talked about last year, and we'll reaffirm this year, is that oftentimes you can overestimate a central jet but underestimate eccentric regurgitation. So if you do see eccentric regurgitation, it's very important to make mention of that. And also some secondary effects. Well, you want to indicate whether you've noticed any downstream effects like early diastolic reverse flow in the descending thoracic aorta imaged by suprasternal imaging, and whether there's been any dilatation of the left ventricle as well. Shunt lesions. Kenny spoke about ASDs and VSDs, and so I won't go through all of them, but just indicate some of the things that you want to mention about simple shunt lesions. Obviously, you want to talk about the lesion itself and location, the shunt, and secondary effects. So if, like this, in this example, we've got an ASD, you want to talk about the location and describe the shunt. Now, it is possible to measure a QPQS, so that's a measurement of the ratio of flow in the systemic versus the pulmonary circulation. And some cardiologists oftentimes ask for that. I've provided some details in some of the lectures about how to measure that. Not everyone will want to be able to do it, but even if you don't measure that, it's still important to give some indication as to whether it's which direction it's shunting in, whether it be whether it's left to right or right to left. Most often, certainly in earlier stages of disease, things shunt from left to right. If that's happening in the opposite direction, things tend to be a lot worse. So if you do observe that, or you observe bidirectional flow, it's very important that you provide an indication of that in the report. And then secondary effects. So with ASDs, obviously, it's a significant shunt. There's going to be dilatation of the right heart. And you may well see some volume overload as well, as you can see on the bottom image on this slide as well. That can occur in diastole and systole. If it occurs in both, you've got volume and pressure overload. If it occurs only in diastole, you're looking more at volume overload. So the way you might explain that then in your report would be to say, secundum atrial septal defect. So there, by using that particular phrase, you've indicated where the defect is located. Provide some indication of size, 15 millimeters in size from with a left to right shunt. Let me just go back a little bit. One thing I should have mentioned to you, when you're measuring an ASD or a VSD for that matter, it's better to measure the lesion with the color flow mapping off, so that because just the nature of the way the colors are displayed on the screen, it tends to merge with the grayscale, and you may well overestimate the size of the defect. Yeah, obviously it's important to get as much information and accurate information as you can. So measure the defect with the color off. You might want to do that by using color until you actually position the calipers so that you can see where it is. And then once the calipers are in place, turn the color off and make the measurement then. So describe the location of the defect, the shunt, whether it be left to right or right to left, and any secondary effects like RV dilatation, whether there's flattening or not of the interventricular septum. Another case, I know this is a little bit dry, but trying to, with cases, make it a little bit interesting. If you're looking at VSDs, we want to describe the location and size of those lesions. We're going to mention a little bit about the shunt and whether it's restrictive or unrestrictive, and Kenny spoke about that a little bit, and secondary effects. So whether or not there's, in this case, remembering that VSDs usually impact the left side of the heart first in terms of changes in chamber size. Want to mention anything like that. So in this particular case, there's a restrictive perimembranous ventricular septal defect. That is to say, there's a defect very high up on the interventricular septum, just below the aortic valve. It's restrictive, which is to say that it's small, and the shunt across the lesion is very high flow. And we saw that with the continuous wave Doppler. And it's such that there's no change in the size of the ventricle. One thing that you may want to mention too about some of these perimembranous lesions is whether or not the aortic valve is functioning normally, because sometimes, because the lesion can be very close to the aortic valve, the leaflets can be, their motion can be impaired a little bit, and that can oftentimes cause some aortic regurgitation. Just before I finish this reporting part, two other things that are really important to make sure that you do is, one, read the request and patient notes, and two, if you're unsure, ask. So this is just an example of a patient I saw not all that long ago, and who I was told had an ASD, came in, and it just so happens that fortunately I'd seen this particular thing a few times, but the patient did have a VSD an ASD at one point, but it had been repaired, and had been repaired using a device, an Amplatzer device in this particular case, and you can see it very clearly there. Obviously the interatrial septum is much thicker than you would expect to see, and you certainly can't see any indication of a shunt any longer. But if perhaps you weren't quite as familiar or experienced with things, you'd be looking at that thinking to yourself, is that I don't know, lipomatous hypertrophy, or is it a mass or something like that? So if you do see something like that, refer to the notes. If that doesn't offer any help, you can, in an appropriate way, ask the patient or ask the referring doctor as well. And it's always worthwhile asking, questions that are sort of asked in a prudent and measured way, It's better to look a little bit silly by asking a question than to look a lot silly and go and write a report that's not indicative of at all of what the case may be. So, any questions? No? Okay. So, briefly, I want to chat about reporting uncommon findings. And let me start just by saying that normally, and you guys perhaps mightn't even need a reminder, but normally when you're looking at images, it's not easy to identify any pericardial fluid. So perhaps you can already tell where I'm going with this one, but from any of the views, normally you see the pericardium very clearly. And obviously you see the pericardium wrapping around, all the chambers of the heart, but you shouldn't see any pericardial fluid. And so as soon as you do, you should start asking in your mind, a couple of questions. Is this, pathological? And almost always with a pericardial effusion, it is. So when we're thinking about a pericardial effusion, there's a couple of things that we want to mention in our report. We want to mention, again, 3 things, and that's the common thread of this particular tutorial. Keep 3 things in mind when reporting. We want to report on the size. We want to report on the extent and whether or not there's any compression, i.e. are there any early signs or are there any significant signs of pericardial tamponade? So the size, we want to measure it at sort of an angle that's not going to overestimate things. So we don't want to make things oblique. So try and do things kind of in a way that enables you to make a measurement that's kind of perpendicular to the line of the tissue you're measuring from out to the pericardium. So whether that's at the lateral wall of the LV or the free wall of the RV or at the apex, you want to kind of keep it at right angles to the line of the tissue. Its extent, most often with a pericardial effusion, we circumferential, but at times after surgery, you might find what's called a loculated effusion, or an effusion that occurs just in a certain area. And that's oftentimes related to a little bit of trauma caused by the surgical process. And then compression, and obviously that's the worst case scenario. If you see that kind of thing, well, almost always the patient will be certainly breathless, perhaps hypertensive, and these are the kind of patients that just don't walk in through the door typically. If you see any signs of compression, and where you'll see compression in the first place is in the atria because they are lower pressure than the ventricles, you need to get a move on about mentioning that to people, that people need to know about this quick smart, because that pericardial effusion needs to be drained. So just to wrap things up here, you might in the first case want to say small circumferential pericardial effusion measuring 6 millimeters at the LV apex, and neither of those two were small, but this is just an example of a way that you might want to write it. No evidence of atrial compression, no significant variation in LV filling. If you want a little bit more detail about that, I won't go into a long explanation, but there are a few things that we've already said about tamponade, both in lectures and in another tutorial that's available via the view site. The one other thing that's perhaps uncommon, but important to describe well, is if you see a cardiac mass. And what I want to highlight is that you can see a mass in any of the chambers of the heart. So the most common lesion is a myxoma, but lesions, masses, vegetations can occur elsewhere. Thrombus, can occur elsewhere. So you want, if you see something about this, you want to be very clear about its location. That's a really important thing to mention. Another thing that you want to mention is its size, its mobility, its appearance, and secondary effects. So unlike the others, there are really 4 things that you want to keep in mind here. So the location, which chamber is it in, or what valve is it, most closely associated with? Is it mobile? Because this can give some indication of what kind of lesion you're looking at there, as does the appearance and any secondary effects. So, for example, you might want to write something like this if you see a mass, a large, irregular, granular and mobile mass. So just by using some very precise terms, you've made it very clear about the size of the lesion, its shape, its appearance and mobility, and then you extend that further and you talk about dimensions. So 20 by 15 in the left atrium, which appears to be attached to the interatrial septum. So, in a short sentence there, you've made it pretty clear that in all likelihood you're looking at a myxoma there. Secondary effects will really, you want mostly to be talking about, does it compromise blood flow? You want to know whether or not it's impeding blood flow. So with that in mind, if masses occur within a chamber, normally you want to work out whether it's impeding blood flow. If you see a mass or a vegetation on a valve, typically what you'll want to be measuring there is regurgitation. So a mass, a vegetation on a valve typically impacts the leaflets, coaptation, so there's regurgitation. A mass within a chamber, it's the way it affects flow is typically by restricting the flow. Let me just hop out. Any questions before I go on to the next section, which won't be very long? Okay. A couple of other things. Again, like what we spoke about earlier on, if you see something and it's really jumping out at you, try as best you can to remain calm, keep calm, like all the signs we're seeing at the moment about coronavirus, and try as best you can to just continue on with your sequence, especially if you're in a fairly stable setting. It's different if you're in intensive care, or even more different if you're in the emergency room. But if you're in an outpatient clinic or something like that, and you see something like this, obviously you want to be able to document it as well as you can, and read the patient's notes, because if you see something like this, well, it may have been there for a long time. As a matter of fact, these images are quite old, and in subsequent years, 5 years later, this patient continues to return to a clinical practice and has that particular lesion, which is a papillary fibroelastoma, in exactly the same location, and causing similar anxiety for the sonographers, but really no problems for the patient. As a matter of fact, the patient was asked if they wanted this lesion removed, but because of significant other comorbidities, chose not to have heart surgery. So each time It's just a matter of getting some really impressive images and working out whether or not they are similar to previous ones. And that leads me to my last point. What you want to be doing with any reports is making use of what people observed previously. So that's a key, I think, take-home message. If things are similar, cardiologists tend to like that. If they're not, that's when they get a little bit more concerned about things, and obviously when patients need to be concerned about things as well. Some other important matters. So obviously once we've finished imaging, and you guys are aware of this, I know, but I just want to reaffirm it, is when we're finished imaging, we're not finished with the patient. It's really important that we then do everything that's necessary in order to, either transfer the patient out of the room we're in back into the waiting room, or enable them to get into the wheelchair where maybe the porter that's taking them back to the ward, or enable them to then be placed in the hands of a carer. And almost always a patient will want to know something about things. Now, this is just a reminder that really, again, we need to be prudent here and say, yes, I've got good images and measurements, and I will be able to report those. The report will go straight to the cardiologist or the referring physician, and he'll be able to tell you more, or she will be able to tell you more. It's not our role to be deliberating on what might or might not happen. It's our role to provide quality images and measurements, and then a report to the appropriate person, a well-written report, obviously making things very clear as outlined above. And then, yeah, if you see something interesting, obviously talk to your colleagues about it, but try and involve the cardiologist too. And obviously they're the experts really with regards to clinical findings, and this is a really nice way of tying in what you've seen with the clinical picture. And I can't recommend this highly enough, is discuss findings where possible with the cardiologist. Now, I know they're busy people, and I know that this is not always very easy, but make the most of those opportunities when they present themselves. And finally, of course, even without the current pandemic, it's important, whether or not we're in a setting where we know a patient has a virus or some other disease or not, we still need to practice good hygiene. Obviously, we want to wash our hands, we want to wipe down transducers, ECG electrodes and machines. And one good thing too that I can recommend is, if your practice is not in the routine of perhaps limiting movement of ultrasound machines to perhaps one or two that are used specifically for mobile echoes or move around, that's a good way of limiting the spread of disease by keeping things relatively stationary. Now, of course, one of the great benefits of ultrasound is that it's transportable, and I don't want to be limiting one of the advantages of it, but obviously doing things in a sensible and intelligent way. So just to wrap up, we've spoken about some simple heart lesions, congenital heart lesions, and how to report them, how to report some uncommon findings. Obviously, we've not gone through everything, but I hope the process that I've mentioned is clear, and you can perhaps use that in other settings as well, and execute some additional important matters following an examination. So that brings us to an end of that tutorial. And I'm conscious of the fact that you've been concentrating on things for 2.5 hours now, so you may well be getting a little bit fatigued. But I'm here to answer questions. If you have any, please do so. I'm able to answer them, I hope, whether they be about congenital heart disease or reporting, or some of the plans I mentioned earlier about the practice of cardiac sonography unit. May I just tell you, remind you again that there'll be a survey coming out very soon. Would be really helpful if you all completed that survey, so that we know where we all stand, so that we can start, planning as best we can to support you and to do so in the best possible way. So keep an eye on announcements, and I'll via the announcement show you how to access that. I hope you're all well. I hope your family and your friends and your colleagues are well too. Allow me just to mention again some of the things I mentioned yesterday. Obviously, keep make your family your priority at this time. I know it's not easy, especially if you're working from home, but try and or do your best. Remain your most patient. Get some exercise where you can. In between, rewatching lectures and all that kind of thing. And I've got a question here. I'll just try and answer that. If a patient has normal blood pressure and then say a BP. So if a patient has a small increase in blood pressure, I think, I'm not an expert on blood pressure. If there's a small increase, I think there's nothing too much to worry about. And, obviously it's not our place to be going and telling patients, all there is to say about blood pressure. But I guess for our own peace of mind is what Lucas said earlier, is transient increases in blood pressure are normal. So, for example, it's not uncommon for a patient to come for an echocardiogram and have elevated blood pressure. As a matter of fact, it's not uncommon for a patient to come to a doctor, and you all know of the phrase white coat syndrome. What is abnormal is chronic elevation of one's blood pressure. So transient increases happen, and they are normal. They may be related to anxiety. They may just occur in regard to some hormonal changes. They're related, of course, to exercise. Any of you who do exercise stress testing will be very much aware of the fact that during an exercise stress test, the blood pressure goes up. That's a normal response. And obviously there are limits, but so I hope that answers that question a little bit. In short, it's a chronic elevation of blood pressure that is the worry, not transient ones.